Acute Respiratory Distress Syndrome, ARDS. Introduction. Acute Respiratory Distress Syndrome, ARDS, occurs when fluid builds up in the tiny, elastic air sacs, alveoli, in the lungs. The fluid keeps preventing lungs from filling with enough air, which means less oxygen reaches to the bloodstream. This deprives the organs of the oxygen they need to function. The syndrome was first described in 1967, and has been referred to by several terms, including shock lung, wet lung, post-traumatic lung, congestive atelectasis, capillary leak syndrome, and adult hyaline membrane disease. ARDS typically occurs in people who are already critically ill or who have significant injuries. Many people who develop ARDS don't survive. The risk of death increases with age and severity of illness. Definition. Acute Respiratory Distress Syndrome, ARDS, is a sudden and progressive form of acute respiratory failure in which the alveolar capillary membrane becomes damaged and more permeable to intravascular fluid, resulting in severe dyspnea, hypoxemia and diffuse pulmonary infiltrates. Acute Respiratory Distress Syndrome, ARDS, is a sudden, progressive form of respiratory failure characterized by severe dyspnea, refractory hypoxemia, and diffuse bilateral infiltrates. Etiology and risk factors. Direct lung injury. Common causes. Aspiration of gastric contents or other substances. Viral bacterial pneumonia. Less common causes. Chest trauma. Embolism, fat, air, amniotic fluid. Inhalation of toxic substances. Near drowning. O2 toxicity. Radiation pneumonitis. Indirect lung injury. Common causes. Sepsis. Severe traumatic injury. Less common causes. Acute pancreatitis. Anaphylaxis. Prolonged cardiopulmonary bypass surgery. Disseminated intravascular coagulation. Multiple blood transfusions. Narcotic drug overdose, e.g., heroin. Non-pulmonary systemic diseases. Severe head injury. Shock. Massive blood transfusion. Pathophysiology. Phases. 3 distinct stages, or phases, of the syndrome including exudative stage, proliferative, or fibroproliferative, stage, fibrotic stage, exudative stage, 0 to 6 days. Characterized by accumulation of excessive fluid in the lungs due to exudation, leaking of fluids, and acute injury. Hypoxemia is usually most severe during this phase of acute injury, as is injury to the endothelium, lining membrane, and epithelium, surface layer of cells. Some individuals quickly recover from this first stage, many others progress after about a week into the second stage. Proliferative stage, 7 to 10 days. Connective tissue and other structural elements in the lungs proliferate in response to the initial injury, including development of fibroblasts. The terms stiff lung and shock lung, frequently used to characterize this stage. Abnormally enlarged air spaces and fibrotic tissue, scarring, are increasingly apparent. Fibrotic stage, 10-14 days. Inflammation resolves. Oxygenation improves and extubation becomes possible. Lung function may continue to improve for as long as 6 to 12 months after onset of respiratory failure, depending on the precipitating condition and severity of the initial injury. Varying levels of pulmonary fibrotic changes are possible. Clinical manifestations. Early signs, symptoms. Restlessness. Dyspnea. Low blood pressure. Confusion. Extreme tiredness. Mood swing. Disorientation. Change in LOC. Cough. Fever. Late signs and symptoms. Severe difficulty in breathing, i.e., labored, rapid breathing. Shortness of breath. Tachycardia. Thick frothy sputum. Metabolic acidosis. Cyanosis, blue skin, lips and nails. Abnormal breath sounds, like crackles. Decreased PaCO2 with respiratory alkalosis. Decreased PaO2. Diagnostic evaluation. Complete history. Take complete medical, surgical, medicine, personal, socio-economic, occupational history. Physical examination. Listening to the chest with a stethoscope, auscultation, reveals abnormal breath sounds, such as crackles, which may be signs of fluid in the lungs. Often, blood pressure is low. Cyanosis, blue skin, lips, and nails caused by lack of oxygen to the tissues, is often seen. Laboratory investigations. Arterial blood gas analysis. Blood tests. Chest X-ray. Bronchoscopy. Sputum cultures and analysis. Chest CT scan. Echocardiogram. Electrocardiography. Medical management. Persons with ARDS are hospitalized and require treatment in an intensive care unit. No specific therapy for ARDS exists. Respiratory therapy. Primary goal is O2 therapy to correct hypoxemia. O2 administered by mask. SpO2 continuously monitored. O2 administration is given to patient the lowest concentration that results in PaO2 of 60 mm Hg or greater. When the FeO2 exceeds 60% for more than 48 hours, the risk of O2 toxicity increases. Mechanical ventilation is provided to client. Medications. Antibiotics. Anti-inflammatory drugs, such as corticosteroids. Diuretics. Anti-anxiety. Muscle relaxants. Inhaled drugs, bronchodilators. Prone positioning. About 2/3 of patients with ARDS improve their oxygenation after being placed in a prone position. Mechanisms that may explain the improvement include increased functional residual capacity, change in regional diaphragmatic motion, perfusion redistribution, improved clearance of secretions. PaO2 level in prone is more than supine position. Lateral rotation therapy. To stimulate postural drainage and help mobilize the secretion. The lateral movement of bed is done for 18 to 24 hours slowly. Fluid management. Distinction between primary ARDS due to aspiration, pneumonia, or inhalational injury, which usually can be treated with fluid restriction, from secondary ARDS due to remote infection or inflammation that requires initial fluid and potential vasoactive drug therapy, is central in directing initial treatments to stabilize the patient. Nursing management. Ineffective breathing pattern related to decreased lung compliance, decreased energy as characterized by dyspnea, abnormal ABGs, cyanosis and use of accessory muscles. Impaired gas exchange related to diffusion defect as characterized by hypoxia, restlessness, irritability and fear of suffocation, hypercapnia, tachycardia and cyanosis. Risk for decreased cardiac output related to positive pressure ventilation. Ineffective protection related to positive pressure ventilation, decreased pulmonary compliance and increased secretions as characterized by crepitus, altered chest excursion, abnormal ABGs and restlessness. Impaired physical mobility related to monitoring devices, mechanical ventilation and medications as characterized by imposed restrictions of movement, decreased muscle strength and limited range of motion. Risk for impaired skin integrity related to prolonged bed rest, prolonged intubation and immobility. Knowledge deficit related to health condition, treatment modalities and hospitalization as characterized by increased frequency of questions posed by patient. Complications. Common complications are nosocomial pneumonia, barotrauma, renal failure. Other complications are O2 toxicity, stress ulcers, tracheal ulceration, blood clots leading to deep vein thrombosis, infections, catheter-related infection, hospital-acquired pneumonia, sepsis, ventilator-associated pneumonia, pulmonary emboli, acute renal failure, endotracheal tube intubation complications, laryngeal ulceration, delirium, sleep deprivation, post-traumatic stress syndrome.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.